Hi everyone, my name is Morgan McMeniman. I'm one of the Queensland X-ray radiologists. I did my radiology training and medicine training in Brisbane before doing a musculoskeletal imaging fellowship at St Paul's Hospital in Vancouver in 2012, and I've been with Queensland X-ray since 2013. We're going to talk about EOS today. We're going to talk about what is EOS, what's the big deal with regards to EOS, some of the applications that we've been using EOS for at Queensland X-ray, the common pitfalls or some of the pitfalls that we've encountered, and then for our referring clinicians online, how to refer. Obviously, we're not going to do a question and answer today. So this is a photograph of an EOS machine pulled straight off the EOS website. Here's a photo of my youngest child in the Cooperoo EOS machine. So you can see they are as advertised. And what is it? Well, the way to think about it is basically digital radiography, so a digital acquisition of plain radiographs, but it's in stereo. So you get the AP and the lateral at the same time over approximately about 175% of 75 centimeters of a person, which is most of most people. So here's a little cartoon from the EOS website sort of showing the acquisition. And you can see the patient has to stand within the EOS machine. You have to stand stationary. And then while you're standing within the machine, two detectors simultaneously sort of move from head to toe, obtaining the images AP and lateral over a course of around about 20 seconds in total, which sounds quick, but for some of our patients, that can be a pretty long time. I think probably the biggest deal with EOS imaging and why it's had such great uptake is the detector. So it has its own particular X-ray detector, which is its main advantage is that it's very sensitive and leads to a really, really low dose examination. And so this has made these EOS machines wildly popular. Last time I did this talk a few years ago, there were over 400 systems. Now there's over 500 systems. I'm sure there's more. There's tons of these EOS machines around the world. It's all thanks to this bloke, Dr. Sharpak, originally from Poland, died in France, who came up with the detector and got the Nobel Prize for his efforts. So when thinking about the radiation of CT, X-ray and EOS, this is a bit of a logarithmic scale. So you've got the fatal dose up here, 10,000 millisieverts, radiation sickness at 1,000, and then 100 about halfway down, and then 10 millisieverts, which is sort of a full body CT rough guide, and then the yearly radiation we get is about 2 millisieverts, and then a chest X-ray is way down here at 0.1, just as an idea. So a single region CT is not so much as a full body CT, so down around sort of the 2 to 3 range. Interestingly, if we're talking about spine imaging, X-rays are not far behind CT. So if you do a lumbar spine X-ray, particularly if you do AP lateral, obliques, and flexion extension, you're heading towards the dose of a low dose CT. So you're not really saving too much by doing plain films instead of CT, but the EOS dose is much, much less. So at least in the order of sort of 5 to 6 times less than an X-ray, down towards mammogram and chest X-ray levels. And if you use the microdose EOS technology, which is even lower, which we can use for small people like kids and things like that, it's a really, really tiny dose compared to plain film. And this is a massive advantage of EOS, and I think why, especially in the pediatric population, it's had a really great uptake. You'd expect with something so low dose that the image quality would be quite poor. I mean, that's what happens with CT and various other things. When you really decrease the dose, the image quality is really grainy and not too great to look at. But here's an EOS from last week at Bowen Hills of a adolescent female patient. And if we magnify up the pelvis part of it, you can see it's very diagnostic imaging. The hip joint spaces are really well seen. The sacroiliac joints are nice. You can see the iliac apophyses. And this is the chest X-ray part of it. And you can even see the horizontal fissure, like it's it's a pretty diagnostic image, and for the radiation dose, I think very high quality images. So we've got a large field of view, simultaneous AP and lateral radiographs. The other advantages are that it's a weight-bearing examination versus CT and MRI, which are almost always performed in the supine position. And then, as we'll talk about in a second, it has some magnification or a lack of magnification advantage over conventional plain radiographs. Weight bearing is super important. So this is a patient who came through one of the Gold Coast practices after a fall in the surf. So he's like a 50-something-year-old lawyer who had landed on his head in the surf. He had a CT, a CTA, and an MRI, and the alignment was the same in all of these images. There were no fractures. There were some obvious soft tissue injuries on the MRI, but he went to see Jeff Askin, who we work quite closely with at Bowen Hills, who was concerned that there was some instability that hadn't been picked up on the CT or MRI. So he just came around to Bowen Hills just for a plain film, and this was his plain film. And so you can see just from moving from the supine position to standing, he's completely unstable at this C5-6 level. These facets have almost dislocated here, and the C5 vertebral body's hanging off the front. So this fellow's not far away from a significant cord injury. He went on to be fused, I think, that day or the next day. But standing up and weight bearing is really important in spine imaging, things like scoliosis and lower limb alignment. So that's one of the big advantages of EOS. The other is the magnification and distortion that we were talking about before. So this is how we used to acquire, and in some places still do acquire, long leg radiographs. So it's usually just a frontal projection only. It's a smaller field of view. The radiographers have to stitch the images together, but you also get these magnification artifacts because a plain film is from a point source. Structures that are at the front of the patient, closer to the source, are magnified compared to structures at the back. And then also at the margins of the film, the vertebral end plates, you're sort of getting them at an angle with a point source rather than end on. If you compare that to an EOS, there's no stitching, obviously, and then that magnification error is markedly decreased because it's a pencil beam. So it just goes straight top to bottom, straight down the patient. There's no angled beam at any point during the acquisition. And then obviously, as we've already discussed, you get a sagittal plane as well. So they're really lovely pictures compared to those stitched together images of the past, hopefully. So they're the advantages as we see it of EOS. And this is how or where we've had our EOS applications. So we've had great uptake with our podiatrists and lower limb surgeons with lower limb assessments. EOS is really powerful at giving accurate leg lengths, some pelvic parameters, which we're going to talk about a little bit later in the presentation, but also a mechanical axis assessment. So this is the standard EOS workup that every lower limb EOS will get. So you get a measurement of the pelvic obliquity. You can see this patient's pelvis is higher on the left. You also get individual measurements of each long bone, along with an alignment assessment at the knees. So varus valgus at the knees. And this will come on every single lower limb EOS. And here are the pelvic parameters that we'll talk at length a little bit more about pelvic incidence and sacral slope later on. We are able to do rotational profiles with EOS. They have not been fully validated in children, so people under 15 years of age, and that's the most common patient for rotational profiles. It does take a while. It's a lot of work for the radiographers. And what we've found in our experience at least, is that some of the orthopedic surgeons that are doing these rotational profiles will do a bit of a screening EOS for the leg length alignment. We'll have a rotational profile as part of that. This is what it looks like. So the radiographers have sort of traced out around all of these long bones. You get a 3D model. So this is not the true 3D map like a CT. This is a model generated by the EOS, which comes up with a rotational profile based on the bony landmarks which can be hard to see in the kids, which is why it's a little bit trickier in kids. But our orthos will do a lower limb EOS. If it's abnormal, then we might move on to a more formal rotational profile with CT or MRI to sort of prove that there is a rotational anomaly at the lower limbs. But that is definitely something that can be done on EOS initially. All right. Now, moving on to the spinal assessment. We do a lot of work at Bowen, as I've already said, with Jeff Askin, and Jeff is a bit of a minimalist, so he doesn't want any workup, any measurements. He just wants the pictures, which is totally fair enough. And so this is a spine EOS. So if we just do the spine, we get this AP and a lateral radiograph, and that's all we send to Jeff, and he's happy with that. You can see this patient has a thoracolumbar scoliosis convex toward the right. But if we move a little bit further along, what I wanted to spend a bit of time today talking about was coronal and sagittal balance. And coronal balance makes much more sense, or it's much easier to talk about. And basically, it's coronal and sagittal balance are all about keeping your head over your pelvis, over your toes, both in the coronal plane, so left, right, and then in the sagittal plane, sort of front to back. And so this is the coronal balance of someone with a thoracolumbar scoliosis toward the right. And you can see it's been measured there between T8 and L2 at 14 degrees. And what we want to check is whether or not the patient's head is still over their pelvis. And so we use a line called the C7 CSL line, which is basically a line from C7 to the central sacral line, so sort of intersecting the mid-sacrum. And you can see in this patient it's 0, which is normal or neutral. And what we're looking for is in scoliosis and other spinal deformities, whether or not C7 is over here or over here and contributing to or indicating coronal imbalance. We use the cutoff of 3 centimeters. So if they're 3 centimeters toward the right, we'll say there's 30 millimeters of coronal imbalance toward the right. But that is a pretty straightforward concept for most people to grasp. And it's really well demonstrated or represented on the EOS images. Sagittal balance is a little bit more complicated. There's a great article by this fellow Rasuli from back in 2011. Rasuli featured pretty heavily in the literature at that time, talking about EOS and sagittal balance. And this journal article is really worth a read if you can get a hold of it. This is a cartoon from the article, and everyone should, recognize that this is our a cartoon of our spinal alignment, and you can see neck over pelvis over feet. But there is something that's pretty unique about our spinal alignment compared to the rest of the vertebrates knocking around, and that's our lumbar lordosis. So we are the only ones with a lumbar lordosis, which allows us to maintain a bipedal posture all the time. You compare us to this bush turkey on the left or this kangaroo on the right. No other animal has a lumbar lordosis or is significantly bipedal without sort of tails and wings and things. Even T-Rex didn't have a lumbar lordosis, but here is ours, and it really is part of the keys of keeping us upright. And then the link, obviously, between our spine and our lower limbs is our pelvis. And I wanted to spend a little bit of time talking about some pelvic angles. I know this is probably the only part of the talk where we talk about angles in a little bit of detail, but stick with me, and hopefully some of you might learn something. A lot of you will already know these facts. So I wanted to focus on just two pelvic angles. The first one's really simple. So the first one is the sacral slope, and it's the sacral slope relative to horizontal. So you can see the superior end plate of the sacrum here, and the sacral slope is just this angle that the sacrum or the superior sacral end plate makes with horizontal. You can see it's bigger here and smaller over here, but pretty straightforward. Okay. So sacral slope, that's angle number one. Everyone should be following along so far, I hope. The second one is the slightly more, the angle that's a little bit less intuitive. And this angle, highlighted in red, is the pelvic incidence. So the pelvic incidence for a person doesn't change. It is, and that's because your pelvis is a pretty set structure. So the bony ring doesn't really move relative to other parts of the bony ring. And the angle is made by a line that joins the center on a lateral projection, obviously, but the center of the acetabulum to the center of the superior sacral end plate, and then a line running perpendicular to the sacral end plates. And so you can see that, if you rotate this pelvis posteriorly, like both of these, so pelvis A and pelvis B have been shifted back a little bit, you can see that the pelvic incidence angle doesn't change because the orientation of the acetabulum to the end plate doesn't change, okay? So we've got these two angles. Pelvic incidence, which is stable, it's different in everyone, but in a person, like if your pelvic incidence is 32 degrees, it's 32 degrees whether you're sitting down or standing up, unlike your sacral slope, which will move with your pelvis, if that makes sense. Hopefully, and this will become a little bit more clear in a couple of slides, but we've got these two angles. Okay, so why are these angles important? Well, this is our initial alignment that we were talking about, the normal spinal alignment with these sagittal curvatures, so the thoracic kyphosis and the lumbar lordosis. As we age and as our spine becomes more and more degenerative, the usual progression in almost everyone is to lose this lumbar lordosis. So this straightens, occasionally becoming kyphotic, and then your thoracic spine, your thoracic spine becomes more and more lordotic. More and more kyphotic. And you wind up with those stooped little old ladies and little old men. It's often accentuated by thoracic crush fractures, which are almost always crushed more anteriorly, leading to a downward gaze. So, these stooped little old people with canes staring at the ground. And this is really, really bad. So once your sagittal balance, once you're stooped forward, your degenerative change will progress more quickly. A downward gaze is associated with all sorts of bad health outcomes. It's an increased falls risk, and it's actually linked to greater levels of depression in the elderly. So it's just bad news. So your body does its best to try and alleviate this downward gaze, and it does this by sort of two main mechanisms. One is at the pelvis, so retroverting your pelvis and extending your hips to try and bring your spine back around to upright, and the other is knee flexion. So hip extension and knee flexion, and the hip extension is sort of linked to pelvic retroversion. All right, and this is where those angles come into play. So here we can see the two pelvises, pelvis A and pelvis B. This is more upright, and then this is pelvic retroversion. And the reason this image is important is, can I convince you that the larger your pelvic incidence, that red angle is, the greater the range of sacral slopes you have available at your disposal, and the more you can retrovert your pelvis. So if you have a large pelvic incidence, you are more able to cope with your advancing degenerative change, and you're more able to retroverse your pelvis, as opposed to this person down here, pelvis B, who has a small pelvic incidence, and they can't do much because your sacral slope can't go past the horizontal, because then you fall over backwards. Okay, so they've got less of a range. All right. So this is what you wind up with on the EOS. So every EOS that has a spine assessment has this reference value table. And so we'll go through it step by step. So first of all, the pelvic incidence. So that's that angle we were just talking about. It'll have a measurement for everyone. There's no theoretic, because it's just an individual measurement. And that's why this graph over here on the EOS is sort of a normal distribution, because you have the normal distribution of the population with the angles along the bottom. And then your patient, or our patient, this patient, is right here. So just past the mean. So a bit of a higher pelvic incidence, meaning they have a bit of play with their sacral slope. And you can see in this example patient, they have a bit of a lack of lordosis. So they are starting to straighten out in their lumbar spine, which is not great, because, as we were just talking about, they're going to be starting to stoop forward. And so we can see that their sacral slope's should be around about 43 degrees based on the other parameters, but it's actually a bit lower at 33 degrees because they're retroverting their pelvis. And so you can see they've got a lack of a lordosis, and now they're retroverting their pelvis. And they're retroverting their pelvis because they can, because they have a higher pelvic incidence. All right, hopefully I'm making sense. And so how do we measure the sagittal balance in the end? I prefer the sagittal vertical axis. So this is similar to the coronal balance that we were talking about. This is just a line drops straight down from C7, and you measure the relation of C7 to the superior end plate of the sacrum, just like the coronal balance, and you wind up with the sagittal vertical axis here. Some people use the cam line, I don't, but it doesn't matter. There are a million lines you can use, and I find this one's the simplest. And you can see in this patient, it's 11 millimeters. So if we go back, we can see our patient that has a lack of lordosis, who's retroverting their pelvis, has actually maintained their sagittal balance. So they've kept their head over their hips, over their feet, by way of retroverting their pelvis. Okay. Hopefully, everyone stayed with me through that. Just to sort of reinforce those points, here's a couple of cases. So here's a patient who we can see is a bit overweight. They've got a bit of an apron. You can see that they've got an L4-5 anterior spondylolisthesis, and you get the impression with all this weight and a bit of degen that they're going to have a positive sagittal balance. And indeed, he did. So here we can see his SVA is 82 millimeters. And just like coronal balance, I use a cutoff of 30 millimeters for sagittal balance. So over 30 millimeters forwards is positive sagittal balance. So this guy's quite forward. And if we go through his pelvic parameters, we can see that his pelvic incidence is on the lower side. Hey, so this is one standard deviation, and it's more than one standard deviation below the mean. And so despite his lack of lordosis here, just like the initial patient, there's minimal pelvic retroversion. And because of that, he's been unable to correct his positive sagittal balance, and he remains sort of stuck anterior to the sacrum and imbalanced. Here's a second case, similar sort of picture. So this person's had an L5S1 fusion. They've got a grossly positive sagittal balance. It was 79 millimeters. And so you can see these dotted lines. So the SVA and the cam line anteriorly here, both of them dotted lines coming down anterior to the pelvis, miles in front of the sacrum over here. So this patient went on to have a thoracoplasty. So they went in and they jacked open between these two vertebral bodies, trying to alleviate that positive sagittal balance and correct some of that down gaze and that stooping. And you can see on the follow-up EOS, both of these dotted lines are now behind the most anterior aspect of the iliac crest. Not back to normal, but a marked improvement compared to the prior examination. To give you a case of something that I find impressive with regards to coronal balance. So here we've got a pediatric patient, and you can see this patient has a thoracolumbar scoliosis toward the left. And if we look, this is one of those very low dose examinations, quite grainy, but diagnostic, absolutely. And we can see the thoracolumbar scoliosis convex toward the left, but also this quite marked pelvic tilt. So the right side of the pelvis is much higher than the left, or pelvic obliquity, I should say, not pelvic tilt. And if we look at the lower limbs, it becomes pretty clear that the right lower limb is much longer than the left. And if we do the measurements, we can see there's just over a 3 centimeter anatomic leg length discrepancy. But what's kind of cool about the kids when we're talking about coronal and sagittal balance is they can have this 3 centimeter leg length discrepancy. Their pelvis can be rotated around to almost, 3 o'clock, but they maintain their sagittal balance, or people try and maintain their sagittal balance, and kids are great at it because they're so bendy. And you can see here that the coronal balance coming down straight through the sacrum, and then sagittal balance coming down. They've maintained their lumbar lordosis, and again, straight through the sacrum. So impressive compensation by this pediatric patient. So what are the downsides of, we've sort of spoken through some of the upsides of EOS imaging, but what are the downfalls? Well, first of all, you've got to be able to stand up. You've got to be able to stand up for 20 seconds, which sounds easy, but for our pediatric patients and for the elderly, to stand completely still for 20 seconds and reasonably upright without, a super stooped posture so that you're halfway out of the EOS machine can actually be a little bit tricky. And for our sort of 3-year-olds and 2-year-olds, we still have to do sort of plain films rather than EOS. As we already discussed, the rotational profile is a little bit limited in those under 15 years. Because it's low dose, it's not technically a diagnostic film. So I think you get tons of diagnostic information out of an EOS, but if I was looking for things like a sclerotic bone lesion or a lytic bone lesion or a fracture line or something like that, I think we still have to stay with plain films or cross-sectional imaging. And for the same reason, in some of our larger patients, image quality is pretty limited, particularly on the AP projection. Just by virtue of that apron, you really can't see too much going on in their pelvis or a few other places. I put a little asterisk next to the standing because we do have one of these at Bowen Hills. So it's a radiolucent chair. Jeff does a lot of spinal surgery on pediatric kids in wheelchairs, kids in wheelchairs. So we do have one of these radiolucent chairs to assess their spines, which is pretty handy. Now, I just wanted to spend the last part of this talk on an artifact that we've noticed a little bit on EOS that everyone can look out for. So it's worth mentioning. This is from a subreddit on panoramic photo fails, but I'm sure if anyone's tried to take a panoramic photo with a moving object in it, you can come up with some pretty strange artifacts. And EOS is sort of like a panoramic acquisition, sort of from top to bottom, and you can wind up with some problems because of that. So here's a patient that came through Bowen Hills, actually, who looked initially like they have a thoracolumbar scoliosis convex toward the right. But if you look closely at the image, you can see that it's not quite right. It doesn't look like a scoliosis. The end plates aren't angled relative to each other. And then everything looks like it's shifted toward the left. So these ribs are sort of poking out on the left. These ribs are poking in on the left. You can see that the waist is accentuated on the right. And what's actually happened is this patient has had a little sway as the EOS machine has taken its acquisition on its way down, which has contributed to this unusual appearance that looks like a scoliosis but isn't a scoliosis. And one of the easy ways to pick up on this is trying to measure a cob angle, because there is no cob angle because the end plates are still vertical. So at the margins of the curve, the apparent curvature, the cob angle is 0 degrees. So just something to be mindful of. We brought this patient back and just did a repeat EOS, and you can see there's no scoliosis when they're not swaying side to side. So just a little artifact I thought I'd mention toward the end of the talk. So the cost to the patient is minimal with EOS. So for specialists and GP referrers, it's bulk billed. For podiatrists, lower limb is bulk billed. And then for physiotherapists and chiropractors, the whole examination is bulk billed. And I think they can have one per year. So that's pretty good. So low dose and no cost to the patient. If you're going to refer for EOS, we'd ask that you either indicate whether you prefer a lower limb assessment or a spinal assessment. And all of the spinal assessments will include a postural assessment and a sagittal balance. We can do limited spine imaging like the Askin if it's preferred. At Bowen Hills, we can do the seated imaging, and on request, we can do rotational profiles. And obviously, you can refer to Queensland X-ray at Bowen Hills, Coorparoo and Taringa at the moment. We've also got regional EOS machines in Cairns, Mackay and Townsville. So just to briefly summarise, EOS its main advantages is that it's a low dose, weight-bearing X-ray technique. It's got a really big field of view and minimises magnification errors. We've found it most helpful at Queensland X-ray in scoliosis diagnosis and follow-up. To assess, do a postural assessment, so coronal and sagittal balance, and for lower limb assessment, leg length and alignment. And that's the conclusion of the talk. Hopefully people online got something out of today's presentation. Thanks for your attention.